That's okay.
Some of this is a little bit still new to us. We're
No
learning every
worries.
time we do it.
Yeah, it won't pop up on. It won't pop up on this until it's kicked off on there.
Published it. We're going to go live at 9. And I'll get a countdown.
There it is. Yeah, it just came across. Just got a text message on my.
Okay. Have to actually push publish to do that. So. Alright. I'm going to get your. You got the water ready. I'm going to use the restroom.
Okay. So we've got 9 minutes.
9 minutes. Yeah.
8. Count
8. Okay. Sorry.
9 minutes and a half ago.
How's you, man?
Running absolutely crazy. So it's been running around. We got a bunch of stuff that's not on there yet, but some of the stuff we've done live to people live with people.
Okay.
Top on there, subscribe.
Okay.
Share. We got other stuff that's coming on there. It's just anything that we try.
I've got a couple links to send out to you. Oh, it says it's live right now. And I'm standing there playing on my phone.
We're live.
Oh, okay.
Okay. Well, just whenever you're ready to go.
Just whenever
Yeah, we're live right now.
That's funny. I'm glad we weren't talking
That's
about
right.
anything inappropriate.
Yeah, we're live. We have been.
Yeah, there's a picture of me up there playing on my phone.
Good.
Sorry, guys.
Alright. We're live.
Well, good morning, everyone. My name is Connor Bounds. I'm going to be giving a presentation today on EMS identification of CHF, and then a second presentation over hypoventilation syndromes. Sorry about some of the technical difficulties. I'm glad you guys got to see me messing around on my phone. So yeah, there you go. So we're just going to get started right now. So a little bit about myself. As I said earlier, my name is Connor Bounds. I'm a paramedic with Sedgwick County EMS in Wichita, Kansas. In 2015, I completed my Master's of Science at KCU in Kansas City. I have my Associates in Paramedicine in 2014 through Cali College, and I completed my EMT training with my biology degree at Missouri Southern in 2010. So just kind of a little caveat, I guess, if you will. Number one, the opinions expressed here are not the opinions of my employer. They are only the opinions of me, and I have no financial interest in any of this stuff. So there's my disclosure statement, if you will. So our objectives today, we're going to define congestive heart failure. We're going to understand the development of congestive heart failure as a result of different causes. And then finally, we're going to outline the pre-hospital management of CHF, including the mechanism by which all these treatments work. So this is a thing for you guys. You can type in on your devices and everything. What would you say is a good working definition for congestive heart failure? So you guys can type that in, and when you send those in, we'll take a look at a couple of them, and then we'll kind of talk about it. So we're going to start off with a case study. So what would you do? You're sitting at your station one day, you get a call on the radio, Medic 32, respond from post 2 on a respiratory call, priority 1. So first thing we're going to do, right, when we come in is going to be a scene size up. So you arrive on the scene of a well-maintained, single-family home. There's no cars in the driveway. And you find a middle-aged man standing at the end of the driveway. And as you start to get out of your ambulance, he yells at you, "It's my dad. He's having trouble breathing. He's in here." He leads you inside to the house. So you arrive in a back bedroom, and you find a 68-year-old male. He's seated in a tripod position on the edge of the bed, and he's very clearly in respiratory distress. Your EMT partner turns to you and says, "What do you want?" So, you make the call. We need to talk about the steps in the examination of this patient. So while you guys are going back and typing in your definition of CHF, I also want you to list what steps you would do in examining this patient, and once you send those in, we'll come back and actually talk about those. So, let's discuss the pathophysiology of congestive heart failure, CHF. So what CHF is it is some kind of injury to the heart that produces poor cardiac output. There is not enough blood going out of the heart to get to the tissues necessary to basically sustain life. So let's discuss a little bit about our normal physiology. So we have a song for you guys today. It's the old Bayer aspirin song. So let's discuss how blood flow goes through the body.
The right atrium is where the process begins, where the CO2 light enters the heart.
Oh no.
Buffering.
Buffering. Is the song going to work?
He uses a lot of internet.
Okay. Alright. So, technical difficulty, that's okay. We'll go over this. Alright. So, what we have is we have the right side of the heart, two chambers, the right atria and the right ventricle. The right atrium receives blood flow from the body, from the inferior vena cava, and from the head and neck is drained by the superior vena cava. From there, it goes into the left ventricle, where it is pumped out into the pulmonary circulation, which will be very important when we talk about the CHF later. After pulmonary circulation comes back around, enters the left atrium, where it's been oxygenated, down into the left ventricle, and then out into the body. So that's the normal path of blood through the body, and as we discuss the development of CHF, we'll talk about how that can go haywire. So here's a content check. You guys need to answer this question. Which of the following is the fastest growing disease in the United States? Is it A, hypertension, B, heart failure, C, opioid abuse, or D, cancer? And have we had any answers to any of the stuff from earlier yet? I'll take that as a no, and we'll continue.
No, nothing yet. So
Alright, okay, no worries. So, let's talk about the actual causes of CHF. We're just going to hit about 4 of them. These are kind of some heavy hitters. We're not going to throw any crazy zebras or anything out there. This is some common stuff that you'll see in the field. So, let's discuss our normal kind of balance, if you will, before we actually develop congestive heart failure. So here we have the alveolus in the lung. And then this is our alveolar capillary bringing blood by the alveolus. So we have basically 4 pressures that are responsible for maintaining the fluid balance in the lungs and the blood. We have the hydrostatic pressure, which is actually in this case it would be the partial pressure of oxygen in the blood. In the alveolus. We have the colloid oncotic pressure, which is just proteins and stuff like that in the alveolus, which acts kind of like through osmotic pressure. It pulls water into there. We have the hydrostatic pressure in the capillary, which is actually our blood pressure, and then the colloid oncotic pressure in the capillary, that is the proteins and stuff in the blood. So you can see by which direction everything will move. So if we have an increase in hydrostatic pressure here in the capillary, we're going to push fluid out into the alveolus. That's the kind of the pathogenesis of the heart failure, if you will. So one of the causes, myocarditis. So we have our ugly, nasty virus over here. He's in the heart, he's in the body, he's looking for something to munch on and cause problems. So he starts breaking down the actual tissue in the lung itself. So as the cell breaks that down, we have an immune response come in. All right, we've got all our white blood cells. We have our different interleukins and different things that are part of the immune response that come in, and those will actually begin to kind of flood the area. Well, one of the byproducts, if you will, of the damage to the cells is we don't have intact walls of the bloodstream anymore. So now you have a dike that's essentially been ruptured. You have a bunch of extra stuff that's flooding the area. Well, it's going to go from an area of high to low pressure, and it's going to move into that alveolus, and you're going to get your heart failure there. You also have cardiomyopathy, so as a result of not being able to push fluid out as well through the process of the heart failure, the heart actually begins to try to remodel and restructure itself, and the heart grows, but that's just a byproduct of that infection there. So, signs and symptoms. There's some common signs and symptoms of the myocarditis. You can have some fever, cough, maybe a little bit of dyspnea with exertion, those kind of things. Some of the more common, though, are heart failure, what this whole topic is about, to the point of not being able to adequately exchange gases at the cellular level. And then also you can be put into arrhythmias, you can have MIs, those kind of things. So let's take a look-see at this right here. So you shoot your 12 lead on your patient. Do we see anything here that is of concern? Well, let's start at the beginning. So let's just take a look at lead 2. All right, we've got a fairly regular rhythm here. We have a rate of somewhere maybe just shy of 150, so we've got a tachycardia of some type. All of our P waves are normal, they're monomorphic, they're all upright, so we're going in the right direction from the SA node down to the AB node. Our QRS complexes are all narrow, so we don't have any bundle branch blocks or TCA overdoses or anything off the wall like that. But there's a couple of things that are of concern over here. So if we look at lead V2 and V3, we do have a little bit of ST elevation there. If you look specifically in V2, we have what are known as hyperacute T waves. We've got a T wave that upslope on it isn't kind of a half circle smiley face, it's a straight line almost, which is a little concerning. And then if you look over here at our baseline, we're creeping up on the 2 millimeter of elevation line there, both in V2 and V3. So, in this case, 2 millimeters of ST elevation in 2 contiguous leads. Well, now we've hit the basic diagnosis of a STEMI. Well, you can always transmit this to your local emergency department and say, hey doc, based on patient presentation and history, I'm thinking it's more along the lines of a myocarditis. But do know that in the case of myocarditis, this can become, if it's bad enough, a STEMI mimic. So we need to be aware of that. One of the other big things for heart failure is our myocardial infarctions, our heart attacks. So we have to remember that our tissue that is involved in the MI is both chemically and mechanically inert. Doesn't work anymore, right? So we can't move an action potential through there, and even if we could, the cells have been so destroyed by the infarction that they're not going to be able to do anything anyway. So one of the things that you'll find here is this area of systolic stretch, and what happens is where you have that non-functional muscle, as your heart contracts to pump the blood out, this does not contract inward, instead it bulges outward, almost like a pouch. Well, if we're bulging outward, we're not kicking anything out into the aorta, we're maintaining a lot of blood here in the left atrium. Well, or sorry, in the left ventricle. Left ventricle's full, left atrium's full, left atrium's full, we're not returning any blood back from the pulmonary circulation, so you can see where your MIs will lead to your heart failure. One of the other big causes of heart failure in the U.S. is our chronic hypertension. I know that in the last month or so they've kind of updated their diagnostic criteria for that. I'm not going to delve too far into that. I'm going to use some of the older criteria because the new stuff hasn't moved into EMS all that quickly. But if we take our cutoff for hypertension and make it 140/90, for every 20 millimeters of mercury over 140 in our systolic blood pressure, and for every 10 millimeters of mercury over 90 in our diastolic, you have a 2-fold increase in risk of death by cardiovascular disease of any type. So if you've got somebody who's walking around and their baseline is their systolic is 160, well, they've got 2 times the risk that they're going to drop dead from sudden cardiac death sometime in the next year. And there's also a 2 to 3-fold increase in heart failure in these hypertensive patients. So, yeah, go to your doctor, get checked out, manage your blood pressure. So let's talk about how the hypertension can actually cause issues with the heart failure. So, hypertension increases our preload. So if we have a larger amount of pressure in the body, we're going to be returning more blood to the heart, increasing our preload. In doing so, through the Frank-Starling mechanism, we actually have to move that blood. So the heart, to compensate for the hypertension, begins to produce ventricular hypertrophy. So you can see here where there is almost no space over here in this ventricle, and just the entirety of the wall of the ventricle is increasing, so that's dropping our volume there that we can take. Well, again, just like the MI case, if we don't have any volume here, we can't pump it out. We can't pump it out. We can't receive any more blood. We're going to be backing everything up into the pulmonary circulation and causing that heart failure. So that reduced ejection fraction, so the amount of blood that it receives compared to the amount of blood that it's getting out, or that it's ejecting, as that fraction goes down, we get the backup in the pulmonary circulation, and we get the pulmonary edema. Another one that we'll run into occasionally is toxins and chemical burns. In this case, a big one, especially for little old people with a whole slew of other morbidities, is pneumonia. Kind of like earlier with the myocarditis, you get that pneumonia-associated lung damage as a result of the immune response to the infection there. Another big one is your toxin-induced congestive heart failure. This was a big one back in World War I. Chlorine gas, the use of chlorine gas as a weapon of mass destruction and chemical warfare can cause chemical burns. Those burns, again, just like the myocarditis, breaks down the linings of the capillaries and the lung tissue and everything, and causes problems. So this is kind of how it progresses from our normal alveoli. So we've got our normal blood flow going on in here. There's a little bit of interstitial space, oxygen and gas exchanges occurring normally. Well, here's our hypertension right here. Okay, so we've got an increased hydrostatic pressure. That blood pressure is going to start pushing fluid out into the alveolus, and then you start getting that filtered plasma in there, and there's our pulmonary edema. So, how does our body try to overcome the congestive heart failure? This is how our body does it before anybody even places the 911 call. So we have 2 main mechanisms by which we do that. The first one is and you guys are going to have to go with me way back to paramedic school now, is the Renin Aldosterone Angiotensin system, and the other one is our sympathetic nervous system. So the first way we do it, the Renin Angiotensin Aldosterone system, the RAAS, that purpose of that system is to retain fluid and basically increase our circulating blood volume. So even though we're not pushing any other blood out and we're starting to develop this heart failure, we're not moving blood around the body appropriately, our body senses that and goes, whoa, 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 time out. I've got to do something to get my blood volume up. So it activates this system. And it's kind of a complex mechanism. It can be. We'll shrink it down and just kind of hit the high point on it. But sensors in your body recognize the low blood pressure, and you actually have a little apparatus, if you will, in your kidney. It's called the juxtaglomerular apparatus. But anyway, that releases this enzyme called renin. So you got your low blood pressure, Your renin comes out from the kidneys, it starts circulating around the bloodstream. It's an enzyme, so it's looking for proteins to chop up and do fun stuff with. Well, we have a naturally occurring enzyme called angiotensinogen that is in the bloodstream. Those two combine and it cuts it up and forms this angiotensin 1. Well, that's all great and good, but the angiotensin 1 doesn't really do anything. It needs to be processed further by the body. So we go up to the lungs and we convert it into angiotensin 2. Now, this is a little segment where it might be important to know these two steps. So in between angiotensin 1 and 2, we have an enzyme called angiotensin converting enzyme. It tells us exactly what it does. It changes from one form to the other. That's located in the lungs. So we have the angiotensin converting enzyme inhibitor, or ACE inhibitors. So these people with high blood pressure are on ACE inhibitors, and this right here is the segment of that pathway that medication actually works on. So they don't convert from these two, and so it lowers their blood pressure, because the angiotensin 2 will return to the kidneys where it does two things. The big one here is it causes the body to reuptake sodium. So rather than excreting sodium in our urine, we're retaking it back up into the body. And remember this kind of key phrase: water follows salt. You know, you got these people who go out and they eat a bucket of Kentucky Fried Chicken and mashed potatoes, and they've already got some heart failure. Water follows salt. They're going to have some more issues. But anyway, so the sodium and the water are retained in the body to raise our blood pressure. But then the second thing that angiotensin 2 does is it actually acts as a peripheral vasoconstrictor. And so it will take those vessels in the body and squeeze them a little bit and try to raise our blood pressure, but in doing so, it also kicks a big chunk of fluid back to our heart. Well, if we've already got a failing heart going on here, then we're going to run into increased preload. And this system, while it works great if we're, hemorrhaging from a traumatic injury or something like that, if we've already got some heart failure going on, this system actually is kind of counterproductive. It works to bring our blood pressure up at the expense of putting more work on the heart. So it's not the best that we have, but it's kind of all that we have. So just remember, as I said earlier, this is the gist of it. Low blood pressure, sodium and water retention causes us to try to raise our blood pressure. So the second mechanism that we try to use here is our sympathetic nervous system. Again, triggered by low blood pressure, we will release adrenaline from our adrenal glands on top of the kidneys, and we'll also release norepinephrine from the sympathetic sympathetic nerves around the heart. So we have the peripheral vasoconstriction again. We squeeze those blood vessels, we return the fluid back to the heart. But then we also have a positive impact on both our chronotropy, so the heart rate, it goes up as a result of the adrenaline, and also the inotropy. So our heart is actually working harder to push the blood out, which is great, but again, when you already have a failing heart, you're putting more stress on it. These two systems can be kind of counterproductive. So let's talk about our management strategies of these patients. So, history and physical. Actually, let me go back and talk about one more thing regarding the pathophysiology. There is actually some research that's being conducted right now, and the mechanism is not yet completely understood, but they are saying now that in the case of congestive heart failure, once we start this RAAS system back up, there is actually an uncoupling of the beta receptors in the heart and the sympathetic nervous system. So it's almost like the body realizes, like I said earlier, this isn't the best system, but it's the one that we got. Now maybe we can try to fix it and overcome this salt and water retention. So it's all kind of a balance. It's like a teeter-totter, you've got it on the fulcrum and you're like, okay, do I want to have congestive heart failure over here, or do I want to excrete a bunch of my salt and water? And you're trying to kind of keep everything in balance. So anyway, back to the management strategies. So let's talk about our physical exam of the patient. So as always, we all remember EMT school. BSI seems safe, that's not on here, but we start with our primary survey, right? We're looking for issues with our airway, breathing, circulation, and checking vitals, and that's going to kind of guide our management of these patients. So, on our physical exam, kind of starting head to toe, as you look for the airway, we're going to open it, but as we're kind of doing the airway stuff, we can also take a look at our jugular veins. Do you have any distension of the jugular veins? All right. So, what happens in these individuals as they are not able to have adequate cardiac output, and everything starts backing up in the system? We back up into the pulmonary circulation. We back up into the right side of the heart. Well, if we're backed up in the right side of the heart, none of that blood is moving there. It's all stagnant. We can't drain anything. So we're going to start having the distension of the jugular veins because our brain and face and everything is trying to drain the blood back to the heart, but there's nowhere to go, nowhere for it to go. The volume's all taken up by that blood that's not moving. So that decreased cardiac output causes backup in the jugular veins. And they always say that if you are ever attacked by a group of clowns, go right for the jugular. I don't know, I've heard that joke somewhere before.
I promise you I will.
Yeah. As we talked about earlier, the increased pulmonary blood pressures result in that filtration of fluid, that plasma, out of the pulmonary circulation into the alveolus. So that's where we start getting that fluid. That's where we get those wet, kind of crackly, nasty lung sounds. So let's talk about capnography. So let's say we're on this call. We put the capnography on our patient. We've got an end tidal of over 50 millimeters of mercury, and he's got inspiratory and expiratory wheezing. Based on that stuff and this capnograph, what would you say the patient is in? Is he in congestive heart failure, or is he dealing with asthma? Let's see if anybody answers the questions. Do we have any questions or anything yet?
It takes it a little bit for it to.
Takes a little
bit for it to. You're about a minute behind.
Okay.
When it's actually streaming. So.
Okay. So we know that there is some kind of process going on here that's preventing adequate gas exchange, because our end tidal has creeped up to over 50 millimeters of mercury. Normal's between 35 and 45. So something in here is preventing the patient from returning the blood to the alveolar capillaries, doing the gas exchange, and getting it out. Well, in this case, this is our ugly, nasty shark fin capnograph, which is indicative of bronchospasm. So if you saw this on our patient, we could be thinking, okay, we're more looking along the lines of some kind of immune reaction, probably asthma, and you would treat that accordingly. We'll kind of go back and discuss how you can differentiate between the two. So this individual, he's got an end tidal of 40, normal. We're actually smack dab in the middle of normal on your end tidal. He's got expiratory wheezing though, but he's also got wet lung sounds. And you can see here we've got our normal box-like capnograph. So this is not a bronchoconstrictive process. This is not asthma. This is not COPD. This is something else that's going on here. So one of the things that was taught to me very early in starting as a paramedic was all that wheezes is not asthma. So this guy, he doesn't have bronchospasm going on. This is not asthma, but he's still wheezing. And what that actually is this poor guy is getting to the point where his alveoli are so filled up with fluid that he's forcing air out past that fluid, and it's almost like blowing in a whistle. And that's where you're getting that wheezing lung sound. So all that wheezes is not asthma. So this is, again, coming back to it, the big pathophysiology take home. There's poor cardiac output, there's poor venous return, to both sides of the heart. We got filtration of the plasma out of the vasculature, and we wind up with edema. Now, depending on which side the poor cardiac output is coming from determines what type of edema we're going to get. So, if we have the left-sided heart failure, there's poor cardiac output from the left side. That's where we back up into the pulmonic circulation. That's where our congestive heart failure comes from. If we're not pushing anything out on the right side, if we've got right-sided heart failure, we have nothing being drained back to the heart from the body. That's where we get our pedal edema. And it's just kind of a vicious cycle. You know, if you don't get anything back to the heart, you can't kick it out. Well, you're going to still you're still going to be filtering everything out. So it's just kind of, unless you fix this stuff doesn't get any better. So, another thing to remember is that sympathetic nervous system that we talked about earlier as a compensatory mechanism is also responsible for our skin signs that we see in these people. So oftentimes, you know, you will go out and these people will be cool, pale, diaphoretic. Whether it is from congestive heart failure, from an MI, from your diabetics with low blood sugar, that epinephrine, as it is trying to increase your cardiac output and get your blood to where it needs to be, it actually also activates your merocrine sweat glands, which are responsible for sweating. So that's where our sweaty skin signs come from. So it's important to get a complete history as well. So we do our HPI. We ask our patient, you know, what is happening today. And again, I know this has been beaten to death, but we're still going to cover it anyway. A good way to get a basic HPI and then go from there to ask more in-depth questions is your sample OPQRST. Your signs and symptoms, what medication allergies do they have, what medications do they take, their past medical history, last time they ate or drank anything, and the events leading up to the 911 call. And then onset, what were you doing when it happened, provocation and palliation. Is there anything you find that makes it better or worse? Oh yeah, you know, I've been having this chest pain and trouble breathing when I lay down at night. Okay, well, alright, so you've been having this. Have you done anything to try to fix it? Well, I can't get into my doctor for 3 weeks, so I've got every pillow in the house, and it's here in my bed. And you walk back there and you look in, and they're sleeping basically upright like this on 7 or 8 pillows. Well, they've got the orthopnea, you know, they trouble breathing when they lie flat, or specifically the paroxysmal nocturnal dyspnea. So when they lay down to go to sleep overnight, fluid shifts around, they have trouble breathing. Quality, you know, if they're in any pain, well, it's a stabbing pain when I take a deep breath, or it's a sharp pain when I take a deep breath. Does it move anywhere? No, it's all over in my lungs. I feel like I can't breathe anywhere. Severity, you know, if it hurts, you can ask the 0 to 10 scale. In this case, it might not necessarily work if they're not having any pain associated with the heart failure. And then time. How long has it been going on for? So we've got another little content check for you guys here, and we'll see where we can go with this. So, which of the following is the ultimate goal of pre-hospital congestive heart failure care? Are we trying to A, improve cardiac output, B, remove excess fluid and decrease edema, C, reduce the failing heart's workload, or D, improve oxygenation? And I'll give you a hint. This is kind of a trick question. You do one of these things and all of the rest of them will fall in the line. So I'll give you a couple seconds and to think about it, and then we'll go ahead and talk about it a little bit more. So the answer to this question is actually C, reduce the failing heart's workload. If we can make the heart not work as hard against all of the excess fluid that's floating around, a lot of this other stuff will actually kind of fall in line. At least in the short term, while we transport the patient to the hospital. True CHF exacerbation is probably going to require a couple days on the floor at least, maybe the ICU while they work with, you know, doing some ventilator stuff and diuresis and all that jazz. So, and we'll come back and talk a little bit more about that in the next presentation. So, improving oxygenation. This is one of those parts. We can still help improve oxygenation. So, is this a matter of needing to provide the patient with supplemental oxygen? Are they having asthma, COPD, or emphysema, an exacerbation of that? They have pulmonary edema. And we'll come back around to that as we discuss kind of the follow-up to the case. So which of the following provides the best evidence to treat for CHF versus asthma or COPD? Is it pulse oximetry? Slap that little red light on their finger and take a look-see. Is it listening to lung sounds? I don't know. Earlier we talked about all that wheezes is not asthma. Is it waveform capnography or is it skin signs? Give me a couple seconds. Rack our brain. And it is actually the gold standard of airway monitoring, and that is waveform capnography. When it comes down to it, looking at your actual picture on the screen, that capnogram or capnograph will tell you what you need to be treating for. If it's a shark fin, you've got an asthma COPD exacerbation thing going on there, and you need to work on bronchodilating that patient. If it's a normal waveform and you got all the other nasty lung sounds and your end title's creeping upward, you're probably looking at CHF. Again, comparing, these are all tools in your toolbox to use. You have to take, none of these can be taken in isolation. You have to look at all this stuff as well as getting a good history and physical on your patient to lead you down the CHF pathway. So, improving oxygenation, this is one of the things we can do. We give some supplemental oxygen and it's going to increase the gas exchange in the alveoli. So, we are actually increasing the partial pressure of oxygen in the alveoli when we provide our supplemental oxygenation. So as you can see there, air does not like fluid. Air really does not like water. Oxygen does not readily go through fluid, which is why congestive heart failure is a problem. So what you can actually do, kind of like with some of the drugs we use in like our overdoses and stuff, we're going to take that resistance to the fluid movement and we're going to say, you know what, if I shove enough oxygen in this alveoli, eventually some of it is going to push through the fluid. And that is just increasing that partial pressure of oxygen. So, you know, you can start off with maybe a nasal cannula. If they're really in a bad way while you're doing everything else, slap them on a non-rebreather at 15 liters a minute. Please do 15 liters a minute. Don't put them on a non-rebreather at 2. I don't understand why they're not getting any better. Well, because they're not breathing. They're breathing worse than they were before. So yeah, increase the supplemental oxygen. Eventually, some of that's going to get through the alveoli and get through there. Removing excess fluid from the lungs. Your guy is still clutching his chest. He's having trouble breathing. He doesn't feel well. What are we going to do here? We're going to give him some nitroglycerin. And nitroglycerin, you know, though we often think of it as a cardiac medication, it works very well for these congestive heart failure patients because as our blood vessels have been constricted as a result of our sympathetic nervous system and that RAAS, the Renin system, I'll just shorten it for time's sake, we don't have a lot of space for the fluid to go back into. So even if we are improving our oxygenation through supplemental oxygen, there's not really more blood that's circulating through there. So what we can do is we can actually take that pipe, if you will, and open it back up a little bit. And we do that with our nitroglycerin. So as the nitro produces the vasodilation, you have an increased transport rate of oxygen because there's more blood that's able to move through that any given chunk of blood vessel at a time, and you also decrease the blood pressure. Now that may seem a bit counterintuitive, but it's actually good because as you open up that blood vessel and that blood pressure starts to go down, we can actually use our Cpap and push that fluid back out. We'll talk about that next. What's that? It's a Cpap machine. It keeps me from snoring in the meetings. Hopefully none of you guys are snoring right now while I'm giving this presentation. If you are, I'm glad that I don't have to listen to the CPAP. So CPAP is our continuous positive airway pressure, and it maintains a positive pressure there at the end of the exhalation, and that will actually force that fluid out of the alveoli. So like I said earlier, all of this is kind of a seesaw thing. We're tweaking individual parts of the patient's physiology and pathophysiology in an attempt to move it as close back to normal as we can, specifically with the goal of improving oxygenation. So as they are trying to breathe out against this CPAP, there is still a little bit of pressure coming the opposite direction, and that will, with the nitroglycerin vasodilating everything, it's going to take that extra fluid, and with just a little bit more pressure from the CPAP, actually it's got a place for it to go now, and so we can push that out of there. So here's one for you. Why don't EMTs and paramedics get CHF? Here's his cup of coffee. For my first trick, diuretic exam. Oh, we've all been there. What's the first rule of EMS? Go to the bathroom when you can. And now for my second trick. Yeah, again, go to the bathroom when you can. Pre-hospital diuresis is totally dependent upon local protocols. I'm a young enough guy that I have never worked at a system that allowed us to do diuretics in the field. So some places still do, but those I think are becoming more few and far between. So another content check. Alright, so a patient activates emergency medical services for a complaint of difficulty breathing. Upon arrival, you find a 74-year-old male who's in severe respiratory distress. He's a little hypertensive. He's 156/102. He's tacking along at 140 beats a minute. He's breathing at 32 times a minute, and he's got a pulse ox of 82% on room air. Family says he's got a history of an MI treated with a stent, and he's also diabetic. So which of these medications can we administer that would reduce the preload on the patient's heart? Is it A, nitroglycerin, B, aspirin, C, fentanyl, or D, Cpap? I'm glad I didn't say medication, because Cpap's not. Anyway, I digress. The answer is nitroglycerin. As we talked about earlier, we can use, if they're having some chest pain, we can use that as well. But the big things here are Cpap is used in conjunction with reducing the preload with nitroglycerin. So, increasing blood pressure is not the key to CHF treatment. Don't look at the patient who's got a blood pressure of 82 systolic and go, hey, this guy needs fluids, and open up, do bilateral 14 gauges and just slam them full of fluids. That's not helping. That's not the problem. We actually want to use those other tools in the toolbox to give some place for the fluid to go. If they've already got excess fluid floating around, we don't need to slam that blood vessel with extra fluid because it's not going anywhere. There's no place for it to go. So again, we reduce the workload of the heart through the CPAP and the nitro. So let's do our case wrap-up here. So we go through and we do our reassessment. Okay, so here we go. He's still got a heart rate of 130. He's at 104/60. He's breathing at 40 times a minute. He's got 87% saturation on room air. I forgot to include capnography, but let's say that his capnogram, his levels are 55 millimeters of mercury, and he's got wheezing in his lungs, all lung fields, but it's a box-like waveform. So we're still looking at congestive heart failure here. So he's compensating. He's got that strong, rapid radial pulse that's coming from the RAAS and the sympathetics. Sympathetics, they tend to kick off a little more quickly than the renin system. That takes a while for everything to get in the bloodstream, find the protein, cut it, get back to the lungs, all that stuff. But either way, those are still both the compensation mechanisms there on the pulse. The abnormal finding, he does have pulmonary edema. He's got those wet, nasty lung sounds. And when you look, he's also got widespread pitting pedal edema. So you go and you push on his calf, and he's indentated, a couple millimeters, and it takes a long time for it to come back up. So we're looking at heart failure on this guy. He's cool, pale, and diaphoretic still. Again, we're going back. Those lungs, those skin signs, sympathetic nervous system is squeezing all the peripheral vasculature, trying to get blood back to the heart to increase cardiac output, and it's activating the sweat glands, so he's a little sweaty. So our treatments on the airway, his airway's patent, so while you're getting everything set up, you throw him on a non-rebreather, and it comes up to 90%. He's still having some trouble with that. So you throw him on CPAP. His blood pressure's okay. It's 104 systolic. You can get away with it. And kind of a caveat, always follow your local protocols, and if there's something that you're concerned about, call medical direction. All right? But usually a contraindication, systolic blood pressure less than 90, don't throw CPAP on. He's on the cusp of it. You could probably get away with it. You note that his work of breathing is improved. He's got better tidal volume bilaterally, and he isn't using his accessory muscles of the neck and chest and rib cage to breathe anymore. And his lung sounds are actually becoming a little more clear. You can still hear some fluid in there, but you know, based on the mechanism of CPAP, that he's probably pushing some fluid out as well. He's still got an okay blood pressure, so you slap an inch of nitroglycerin on the chest to work in conjunction with that CPAP, and again, it allows for more area for that plasma to be pushed back out by the CPAP. So you take him to the hospital. He's diagnosed with new onset heart failure. He's discharged after a 4-day stay at the ICU, and he's going to the heart failure clinic, and he's got to follow up with cardiology. So good job, guys. We saved him. So now I know we run a little bit behind. Are there any questions that anybody's popped up or anything?
Guys, it'll take us just a little bit here for, go ahead and comment your questions if you have any for Connor on this one. It'll take us just a few minutes. We got about a 60-second delay from the time you guys finish seeing this to the time where we're actually at. So if you have any questions, just kind of comment there, and we'll just kind of pause here for a second while everything's kind of popping up and getting caught up.
Thank you, Connor.
You're welcome, sir.
I'll let some questions pop in here, hopefully.
All right, I hope so.
If you haven't already done so, please sign in electronically on the web page. You can see that now. It's that website I shared with you last week. Sign in there. Forgot to mention that earlier. A few little things, you know, like we're all kind of getting used to this new way of doing it. So thanks for being patient with us as we work out a few bugs. We're going to hopefully get a few questions for Connor. We're going to take a break, let Connor take a break, reset a couple things on the stream, and we'll start back in a few. But if you got questions, shoot them out there now, and Aaron will ask Connor.
And I think additionally, Jeff is going to get a couple. Did you get my email with the surveys?
I did.
Okay.
Yeah.
He's going to send out a couple surveys about these presentations today. This is my first time doing one of these, so I just kind of need some feedback on what can be improved, what went well, those kind of things. So he'll get those out to you sometime soon. Yeah, we'll take a couple more minutes.
So Braden has got a question. He's
Sure.
asking, so paste over sublingual, right? As far as the nitroglycerin.
Okay, good question. Some say it's a matter of preference, but there's actually a bit of good reasoning behind using one versus the other. The big thing about sublingual nitro is once you give it, you can't take it back. Whereas the paste on the anterior chest wall, if you start noticing that your patient's developing some hypotension or some chest pain or basically any potential complication or side effect from it, you can take a gloved hand, use a gloved hand, and wipe that off. And so, yeah. But you can also, and the other thing too is, especially if you're using CPAP, once you get a good solid seal on that face mask, you really don't want to do anything that's going to break it, because it can be, I mean, we've all tried to put CPAP on the patients who, you know, they're freaking out, they're claustrophobic, and once you get it on there, you really don't want to rip it off, give them a couple breaths of good fresh air, drop that nitro, and then put it back on. So yeah, once you've got the CPAP in place, preference-wise for me, anterior chest wall, there on that that nitro.
All right, guys, do we have any other questions? Like I said, we'll give it about another 30 to 60 seconds here if anybody wants to pop anything on, and then we'll go for a break for a minute. analysis. Thank you.
You're welcome, Braden. I feel like it's a Wizard of Oz type stuff. Pay no attention to the man behind the curtain.
Right. Is there a couple more comments there? Good. All right. I think that's an applause.
Oh, yeah, thank you.
Good job. Good job, Connor. All right, everybody. Give us about 15. Take a break yourselves like we would sort of do in class, and we'll just sign back in and give everyone a notification. It's right at 10 now on my watch, so about 10:15 or so we'll go back on. So just be paying attention to the time on your clock and watch for that notification to pop through. Thank you.